Good morning or good afternoon. I don't know exactly where you are because you are a lot of people who are connected from all over the world. And then greetings from Saint-Maur-des-Fossés, where I'm talking in the at the factory the factory of Septodon in Paris, not far where the BioRoots and Biodentin are made of. My name is Stéphane Simon. I am professor in endodontics at the University of Paris Diderot, Paris 7. And I don't know what about the regulation of your country, but in France I have to declare my conflict of interest. So I don't have any conflict of interest with the products, with the company who sell the products. It means that I don't have any royalties on these biomaterials. But I have to tell you that I am financially supported to give this lecture, which is not a lecture. That's actually that's a very, very interesting things to talk about just in front of a camera in front of you, and no slides, nothing. So just I will share with you my knowledge and my experience with one product, which is the BioRoot Root Canal Sealer, because I've been using these products for more than 5 years now. Indeed, we were contacted by Septodon, the French company, to run the clinical study to validate this biomaterial as a root canal filler. Probably you noticed that I didn't say root canal sealer. I definitely said root canal filler, and that's a very, very important point, because I will discuss this point a little bit later, because sealer and filler, finally we think that it's the same thing and it's completely different. And that's why BioRoot is for me a very a good innovative product, because it's not a sealer anymore but rather a filler. So in endodontics we know that we have to fight against bacteria, and we have to fight against the possibility of this bacteria coming back inside the root canal after the infection. And we have made finally the root canal treatment is made of 3 parts: shaping, disinfection, and filling. For the last 20 years, we have made a lot of innovation in root canal shaping with the files, nickel titanium, thermal modification of the alloys with the nickel titanium. We started with 12 to 15 files to shape a root canal, and now we have only 1. So I can say that a lot of innovative things have been done on this topic, and now I don't say that it's already there, it's done, but we have few less innovation than it. Irrigation, okay, a lot of innovation as well with the ultrasonic, sonic tips, activation and whatever, but finally sodium hypochlorite is still the gold standard of this. And finally now, for the last 5 years, we come into the filling part. And what could be innovated inside the filling part? Schilder in 1974 showed us that if you want to fill a root canal, you need a maximum of gutta percha and a very, very few amount of sealer. Why? Because the gutta percha is the filler, that's the core of the filling material. And the problem of this gutta percha is that it's not able to seal and to bond on the dentinal wall. That's why we use a sealer. Exactly like if you compare to the restorative procedures, when you fill a coronal decay, you are going to use the composite. But if you use the composite alone, it gets lost, because you need a bonding system to seal, to bond the composite to the dentin. And exactly in the same way, when you drill a cavity and you fill it with the composite, it will never come to your mind to fill this cavity with the bonding and just place a small amount of composite just to say, okay, I place composite. But what is interesting, what is endodontics? Endodontics is exactly based on the same idea. It's just based on the same objective that for the coronal filling. We have a cavity, so in the coronal part it's large and not so deep. And then in endodontics we have a cavity, it's a long one, a very long one, but a very thin one. So that's why we don't fill them both in the same way. So again, on the coronal part, you're going to seal, to bond the composite resin to the dentin. In the root canal system, after you get shaped it, and then you get it shaped and disinfect with the sodium hypochlorite, we have to fill this space. It's exactly the same. And the problem is that it's very complicated to seal it, to fill it, because it's a long, and then the anatomy is very, very complex. So that's why the warm compaction of gutta percha is the gold standard, because that's the only possibility we have to pack a coronal a filling material, inside the root canal, and then having a small amount of sealer. Because some people use the single cone technique. When you do that, at the end, you get a very nice X-ray. You get a nice white filling material on the X-ray. The problem is that you have a large amount of sealer and just a gutta percha bond. It means that you get 50% of the volume of the root canal is made of the sealer. And the problem is that a sealer is not a filler. The sealer is to seal. And we know that if you want to get it on the maximum of its possibility, the thinner, the layer of the sealer must be as thin as possible. Because the sealer is not dedicated to fill a root canal, to fill a space. It's exactly the same when you place a crown on the tooth, you are going to seal it and you use a cement. But the thinner the cement is, the best retention it is. Because the problem of this sealer, the sealer we use, especially the zinc oxide agenol based sealer, they are degradable. They will be biodegradable. They will disappear with the time. And then we are going to disappear, then you will have some space. And this space will be immediately invaded with the bacteria. So that's why the single cone technique is not considered as a good one. If you want to get nice X-ray, it's a good technique. But if you want to get a nice root canal treatment, it's not a good technique. But finally, why isn't it a good technique? Just because the sealer is not done for that. So if I compare the warm compaction and the single cone technique, it is because the Schilder's technique is the best one, but mostly the most complicated one to complete. And then if you want to use it, the learning curve is very long. And that's why a lot of people prefer to use the single cone technique, even if they know that it's not the best technique, but they would get nice X-ray. And then, why do I tell you this story? Just because the BioRoot root canal sealer, BioRoot RCS, enter into the dance now. Because if you consider this, if you see this material, it presents like a sealer. But the advantage of this, it's not a sealer, it's something you are going to use to fill the root canal. So finally, we're going to use the technique of the single cone. It means that I will have one single cone inside the root canal and a lot of filler around. Because the BioRoot is flowable enough to enter into the space, to fill the anatomy, the full anatomy, even if it's complicated, of the root canal space. And then the gutta percha here is not used as the core material, is not used as the filling material anymore. The gutta percha point is going to be used as a carrier. We're going to use it to push this biomaterial as deep as possible inside the root canal. It's going, because it's a taper one, the gutta percha one is going to push the sealer, the filler, the material in the lateral space. We have a taper preparation, then you have a big pressure at the end. And the second reason why we're going to use and to leave a single cone in the middle of inside the root canal is because in any case we have to retreat this root canal. It would be very, very easy to go through the gutta percha point. It would be very easy to remove this plastic material. BioRoot RCS is a BioCeramic, so it seems to be odd. But we'll discuss that a little bit later about the retreatment. But because the BioRoot is a little bit odd, and then we don't have any solvent, we don't have any product to dissolve it. So the only way we can retreat the tooth is to go through the gutta percha material. And that's why we have to leave a single cone inside in the middle of the material. Then we will be able to get a pathway to go and to get the patency and the apical third. So BioRoot is one of the bioceramics. If you go by the advertisement in the last 5-6 years, a lot of journals advertise for the sealer, the bioceramic sealer. But finally, what is the bioceramic? BioCeramic is not a biomaterial. BioCeramic is a family of materials. It's like the composite. We don't say that we have the material which is a composite. We have a material which is a family of the composite. Then the BioCeramic is a family of material. The ceramics, you know that it's you get a feldspathic one, you get the glass, you get the plate, you get everything. You have a lot of ceramics all around, and some of them have a bioactivity. We know that these bioceramics, they are not bioactive, but we consider them as bio because they are bio-tolerated, or they are not toxic. They are biocompatible. As far as the research is, actually, we don't have any proof about the true bioactivity on the periapical tissue or on the soft tissue or whatever. Maybe they have, but so far it has not been proved properly and then very specifically. So what we have to understand that the bioceramics, they are this big family of material. We have a lot of products. If you go, for example, mineral trioxide aggregate is one of a part of the family of the bioceramics, and we have, I don't know, 25-30 products actually on the market on the MTA, that Portland-based sealer cement material. And this big family, don't get a Portland-based cement with bismuth oxide or zirconium oxide, and then we have very small amount of products which are not a mix of a lot of material. They are quite pure. And BioRoot and Biodentin is one of them. They are 3-calcium silicate base sealer. And they are the only, which is only 3-calcium silicate base. You have a lot of, you have other products which are the mix of 3-calcium and decalcium plus calcium hydroxide. But the BioRoot and Biodentin are the only products actually in the market which are very pure of this. They are synthetically made, they are made in the factory, and then you get a powder and a liquid. So that's important because we know exactly what it is. And in terms of research, for the people who do biological research, it's very, very important because we know that when we are going to investigate it with cells and tissue or periapical tissue or whatever, we will know exactly which material is implicated because there is only one, 3-calcium base silicate. And personally, I do like the pure product, at least for that, because I'm doing a lot of biological research. And then for the Portland cement, for example, it's complicated to know if this reaction is due to the aluminium or to the calcium or the silicate or whatever. One of the big advantages of these bioceramics, all of them, that's the sealing ability, that the ability they have to do cross-links between the materials and the dentin. These 3-calcium silicate are going to release calcium hydroxide, and this calcium hydroxide is going to stick and to match with the phosphatus of the dentin, and then that's a cross-link. And what is interesting is that this cross-link and this sealing is going, if you use a normal sealer, a zinc oxide eugenol based sealer, this interface between the sealer and the dentin is going to be degraded. And then with the time, you lose the sealing ability of the sealer. With the 3-calcium based sealer, with the bioceramics, this link is very good and it's not biodegradable. Even if it is, the biomaterial has this possibility to release more calcium hydroxide and then to release these links. And that's why, first of all, this link, this interface is not degradable. And in any case it's degraded, the material is able to renew it. So that's very important because the problem we have in endodontics with the filling is that with the time, most of the time, we lose this sealing ability of this material. We get a lot of micro leakage because with the time, this interface is degraded. With the bioceramics, it's not. So the point is that where is the BioRoot coming from? BioRoot is, it's not absolutely true, but we can consider that it's like a modification of the Biodentin. You know, the Biodentin was initially developed to be a new coronal filling material. And So initially it was developed to replace the composite and amalgams, and now we know that it can be considered as this, but we have to recover it with an inlay, onlay, or crown. Why? Because the biodentin, in biodentin you get dentin, and if you have a look about on the box, it's written dentin substitute. So this material is made for replace the missing dentin, not the missing enamel. And then for mechanical reasons, that's why we have to recover it with something harder, which is supposed to mimic the enamel. So the problem with the biodentin is that the consistency does not allow to fill a root canal with that. So when you see the root canal, except for the apexification or large canals, you won't be able to use the biodentin to fill the root canal space. And that's why Septodon and then some researchers developed this new material to make it more flowable to be able to go and to fill the space of the root canal. And that's very interesting, because in the concept where endodontics is just a modification of the restorative material, and then we understand that the same material, just because of this difference of the viscosity and flowability, it will be able to be used in the same with the same objectives. And we know that this interface is very, very good even in the buccal cavity in the mouth. So in endodontics, I cannot see any reason why this interface will be not a good quality. And so that's interesting, because now we can consider that with the biodentin and BioRoot, you get the same product. One is like a putty and one is like a light material. And after that, you can imagine to do whatever you want. You get, for example, a perforation, the stripping of the root canal. So before we had to fill the two coronal, the two apical third of the root canal with gutta percha and sealer. Just being careful not to push any sealer inside the perforation, and then after that to clean everything and top the root canal up with the BioCeramic. Now we have the same products to be used as the sealer, filler, and perforation repair. It makes sense. It makes definitely sense. If you consider this as the filling material and not as a sealer, you will understand why this biomaterial can change the life of the root canal filling. I agree that it's a new concept, and then when you use the warm compaction of gutta percha, just coming back to the single cone technique, it's quite intellectually it's a little bit complicated. But just think about that. Just when you use, for example, the thermophil, what is the thermophil? That's a carrier with a gutta percha, with flowable gutta percha, and then a sealer. Then consider that your gutta percha point in this technique is the carrier, and around is the flowable material. It makes sense. And the big advantage of this is that you avoid one interface. You avoid an interface of dentin, sealer, gutta percha. You get one interface between dentin and biomaterial. And that's why it makes sense. So, okay, I agree that sometimes we get hypothesis and concept, and we're very important, and we are very little bit pushy, and I give lecture, webinar. So does it make sense clinically? And so I come back, the reason why I'm quite here today is that I was in charge of this clinical research. It was a randomized clinical trial where we compared the outcome at 2 years of the warm compaction technique versus these BioRoot with one cone, with one single cone inside. And then so the paper is actually submitted and under revision, but I cannot give you the true rate, because it's still confidential as long as it's not published. But you can imagine that if I'm here giving this webinar, that's just because the results make sense. We didn't want to show up that the technique was better than the warm compaction. We just wanted to show that, to see if with this technique we have similar results. So why can't we use it for the warm compaction? Just because the BioCeramic, they require some water to do the to set it up, and then when you eat it, you are going to get the water evaporated, and then you lose some you will lose something inside the biomaterial. Not in the biomaterial, but you will have a problem with the interface between biomaterial and dentin. Another question, because the Jerome is showing one question. It says, how easy to retreat it? So yeah, is it possible to retreat root canal filled with this biomaterial? If you go back into the literature, you will find one paper, I think it's Kontakiotis who did this, who investigated the possibility to remove the material from a root canal filled with the bioceramics. And then the conclusion was, yeah, when it's an easy canal, it's possible. But as you know, that it's the problem is that the retreatment, most of the time, it's not easy root canals. So most of the time, they are complicated. And then because we couldn't find any answer to this question in the literature, so we decided to do the experimentation, and then with a master thesis, which will be defended next week now, the 27th. And then we filled 40 teeth, 40 teeth with warm compaction, with 20 teeth with a BioRoot and single cone, and 20 teeth with a single cone and a zinc oxygenol based material. And then we divided this, and then in two groups, one for the senior endodontist, and it was me, and one for the junior GPs. And each of us, we had to try to remove the material from the root canal in 10 cases, 10 BioRoot, 10 zinc oxide for each group. And so I had the idea to record the time needed to remove the biomaterial and to obtain the patency out of the biomaterial. The conclusions very quickly, because we have a lot of statistics on this. Retreatment was possible in 92% of the cases. I missed one canal, and the junior missed 4 canals on the 120 of them. And the second result, very important, is that it took me less time than for the GP. So it was very good for my ego. But it also showed one thing, that root canal can be retreated even if they are filled with the BioRoot. But there is you need experience, a little bit of more experience, and the experience will help you to decrease the time to remove this. But in both situations, for every practitioner's retreatment, disobturation of a root canal filled with BioRoot was possible. Another question just before ending the session. So, does BioRoot reach the small lateral canal? So in summary, is it possible to fill the lateral canals or secondary accessory canals with this biomaterial? On the paper, I had the hypothesis, by thinking about it, say no, it's too sticky, it's not flowable enough to enter inside the lateral canals first. And then because you don't have this pressure that you get with a warm compaction, then without this pressure, you will lose the possibility of this material to go inside the lateral canals. But finally, in my experience, and then with my postgraduate students, we have some cases where we can see the root canal filled, the lateral canal filled with this biomaterial. It means that finally, this biomaterial, when the lateral canals is wide open, you are going to fill it without any problem. But it's not because you don't see it filled on the root on the postoperative X-ray that it won't be filled in the future. Why? Because remember that these bioactive materials, when we talk to them about bioactivity, it's not definitely because they have an action, a bioactive action on cells and tissue. It's just because they are bioactive somewhere. It means that they have a bioactivity. It means that when you get this material inside the root canal, it's going to provide some calcium hydroxide, and these materials are like alive. It means that with the time, it's going to release the calcium hydroxide, and this calcium hydroxide is going to stick and to bond, to cross-link to the phosphate of the dentin. Just imagine that if you have the root canal filled and then the lateral canal there, then the bioactivity of this material will be able to release some calcium hydroxide, which is going to diffuse inside the lateral canals and stick to the phosphate of the dentin. It means that with the time, probably that this lateral canal or accessory canals will be filled with degradable products from the bioceramics. We need more research on this. But when you look about what happens with the biodentin, when you look about the interface, you definitely see that particles of the biodentin are able to diffuse inside the dentinal tubules. They are able to diffuse inside the bonding layer. It's absolutely incredible. I think that it's only we start actually the true research with this biomaterial. But when you see about what happened with the interface with biodentin and dentin, you can imagine that it will be definitely a useful and interesting products in the future for filling these kind of lateral canals. So I don't know if you have more question. So I had 30 minutes just to share my experience and then giving this webinar just in front of you with no slides. Trust me, it's not an easy job. And I hope that you enjoy this. I definitely enjoy to do the job. And maybe that we'll have the opportunity to meet you once in a meeting one day. And then by waiting this time, I wish you a great day and a nice summer. If you have a sunny summer starting like we have in France, it will be definitely a great vacation. Have a good day. Bye-bye.